Thank you, AJ. Thank you, everybody, for joining. We all carry our background with us. So I present as an epidemiologist, and you will see that my presentation is colored by that. I'd like to give a little bit of a presentation about the last 10 years, a quick overview to give you a flavor what the audit has done, where it came from, what we thought the best things were, sometimes also maybe what we think that the not so good things were, to set you up for the panel discussion in about an hour to think about what should the future priorities be. So let me remind you, in 2012, the team at the CEU, working closely together with Professor David Neal on this bid for this National Prostate Cancer, and we were excited. We were invited to put in a bid, and we had to think about the priority areas for this audit. And together with David, we focused our bid on overtreatment, and we focused our bid also on potential undertreatment. We also highlighted the importance of considering improved safety and improved toxicity, and highlighted the need to look at the variation in management across the country, and at the same time, lastly, also to explore and maybe contribute to helping giving men a better experience when they had prostate cancer, experience of care. So these 5 priority areas were explicitly put in the first version of the plan that the audit would focus at. And then I think it's important, especially when we're going to discuss the future in not so long, let's think with this in mind as the priorities, let's think about what happened. So in 2013, exactly 10 years ago, the NPCA was established. It's a partnership, RCS, with the urologist, with the British Uro-Oncology Group, with the London School of Hygiene and Tropical Medicine, where I work. And it is commissioned by NHS England and the Welsh government via AgeScript. And I want to highlight what I think are 5 important features. And I always keep them in mind as what should be in place if you do an audit as this scale. The most important of it is that there need to be a very close clinical methodological collaboration. Without that, I think you are bound to get into trouble. I'm also very keen, and I already said to you, I have my epidemiological background, so I'm probably over-focused on this, but I also think it's important to keep a clinical epidemiological approach. And I'll highlight in my next slide what I exactly mean by that. Clinical epidemiological approach keeps us on track methodologically. Audit and research go hand in hand. It's obvious for me, but it is still sometimes a bit of a contentious issue. The use of national data set is key. Without access, rapid, efficient access to this resource, I think we would be less efficient. And therefore, also, I think all these audits need to be carried out, again, in partnership with data providers, and in this case, data providers in England and Wales. All these key features are all trying to focus on what I call the 3 R's, the three important criteria by which I think we have to judge ourselves. Audits need to be clinically relevant, methodologically robust. In other words, statisticians need to be involved, but also is an element that you have to think about, can we ensure that it's all technically rigorous? And that, I think, is a growing concern. If data becomes available that is more and more complex, more and more different data sources, an element of data science need to work alongside audits to make it all work. So clinically relevant, methodologically robust, technically rigorous, I think is what these audits need to strive to be. I don't want to go in lots of detail because I think Matt and Joe will give you a few examples of what the audit does, looking at the results of the management of newly diagnosed men. So I thought I'd give you a few numbers. So over the last 10 years, we produced 9 annual reports. Sometimes they're quite thick and maybe a bit too thick. The 10th is in the making. 6 short reports. We carried out 2 organizational audits, which give a detailed overview about what type of services is delivered and available on site where, which I feel is essential if you want to use these national data sets to feed back information to local units or networks. We carried out one patient-reported outcome measures and patients-reported experience measures survey, including about 40,000 patients. I always highlight it as one of the highlights of what we did. We don't do that continuously. We did it over a period of 2 years. I will discuss that a little bit later. And we carried out and we organized 4 national events. And the one that we're at the moment is one of those. We developed and validated 4 performance indicators based on really 4 explicit criteria. They need to be clinically valid. They need to be fair. In other words, we need to compare like for like. That means that you have to be able to adjust for the differences in risk between patients treated in different hospitals. It needs to be feasible. The technical feasibility is important, and it needs to be powerful. In other words, we need to have the numbers to come up with meaningful comparisons between providers and maybe also different ways of treating patients. And we had to develop, out of all that data that we have, an appropriate cancer staging algorithm. This is something that we constantly review and update. And then the research component, which I think is key, produced directly linked to the audit, and maybe indirectly, that's even the numbers are higher, but directly linked to the audit, 37 papers, 18 are clinical epidemiological, and 10 are about methods that we needed to develop to make the audits work, and 9 are about questions that I would label as health services research questions. For example, looking at to what extent hub and spoke models have an impact on the treatment that patients get, or to what extent outcomes are better in hospitals that do higher numbers of surgical procedures. And over and above that, it also generated an environment for PhD students, doctoral fellowships directly and indirectly. I think around me now, NIHR projects sprouting up that benefited from the audit doing it in this way, creating all in all a critical mass. I think that is essential to do something at high quality. And then I also recognize that an audit like the prostate cancer audit has 2 pillars. You want 3, because otherwise with 2 you still would fall over, but I think 2 are most important. The first is the ongoing expansions of linked data resources that together linked at patient level create a resource that provide the richness and the clinical relevance that is required. So hospital data has hospital episode statistics in England, the patient episode data in Wales, linked to cancer registry data on chemotherapy, data on radiotherapy, also linked to mortality statistics, the blue blobs in this slide. And then 2 other data sets stand out that I really think we should recognize. The one is data about the our organizational audits, the organizational mapping of the service, and the yellow one is patient-reported patient experience measures, which at the moment we don't collect, which I think should be part of this ongoing expansion of linked resources. The second pillar is the clinical epidemiological approach, and with that I mean a constant focus on variation between providers, or variation in terms of care not meeting standards. And then the epidemiological approach highlights that it's not only that, it's trying to understand why things vary. Why does a patient with the same risk, cancer risk, get different treatments, and why does a patient with the same cancer risk that did get prostatectomy in time get different results in terms of complications, treatment toxicity or cancer cure. These kind of studies, little project looking at the determinants of variation, I think are the strongest evidence to also then support and guide particular targeted quality improvement strategies. I can't be more explicit about the importance of that. My last slide is about. My last slide is no, my one but last slide. I'm sorry, I'm going ahead of myself. Is about Well, if that is what happened, what should happen next? And I think there are a couple of questions that you could ask yourself. Very explicit one. Do we need more additional data to follow changes in practice? And I give a few examples here. Do we need new performance indicators? For instance, looking at local recurrence or disease progressions become more and more important. Now we can follow up with 10 years of experience patients for longer. Cancer registry data, very, very good at recognizing whether it is cancer or not, but not so much to what extent the disease progresses. Patient-reported outcome measures, patient-reported experience measures, should we start them again? Do we need to expand the scope of the audit, include patients with local recurrence and progression, rather than only newly diagnosed patients? An important element is that COVID has made rapid registration data available to us. Not so good as what we call the gold standard data, but we have it a lot more quickly. And should this lead to a more innovative way of monitoring, continuous cumulative monitoring, or even trying to close the audit loop at a national level through to the plan, to the act cycles? And should we focus more on communication and dissemination? We all know about the audit, but still there are lots of people who don't. And the next step about what next is that a national collaborating center for cancer audits has been established. It's part of the clinical effectiveness unit, and the prostate cancer audit will move into that collaborating center, so it has a future as part of that. And I hope that many of these questions, when we put the audit in that center and establish a future, will be answered with yes. And my last slide is about people. I write here the key people over the last 10 years. I should have written some of the key people. David Neal is mentioned several times. I call him the NPCA's midwife. As midwives do, they present at birth and then disappear. That's what good midwives do. And I think he's especially responsible for not making it all too complicated. The emphasis on under-treatment and over-treatment as a key element is key. I have to mention Roger Wotton, the chair of prostate cancer, tackle prostate cancer. I always thought he had a strong patient voice, and sadly he passed away of prostate cancer in 2019. Heather Payne, Noel Clark, captains with a steady hand. AJ Agarwal's chairing this meeting. He's been the oncological dynamo for 10 years. Our research fellows, you will hear Matt, and you have heard Joe already, but also Aaron Sugenturin has been key, providing the energy in the NPCA's engine room. A number of people in charge of methods. I want to mention Adrian Cook. He's a brilliant statistician, but also a bit shy, and there's no picture of him on the internet. And then a few groups in a bit more aggregated form. A really important group is our patient and public involvement forum to give us a robust reality check. The clinical reference group chaired by Roger Kokelberg is really a profound sounding board. The project board offers us to monitor ourselves against the contractual deliverables. And then I haven't mentioned Julie Nossiter. I think she's been with the audit for 10 years as the lead, especially as the one who makes it all happen. So thank you very much for this, and I hand it back to AJ Agarwal.